So, Dr. Rajashekhar Reddi needs no introduction. It's always a pleasure to listen to him, sir. And sir, please don't mind. Once, once as far as introduction goes, it's on a lighter mood. Once Dr. Mehdi Rattan, one of the CMEs, introduced you, your introduction is in your name only. So your name is Raj. Raj means king. Shekhar means he is on the top. And Reddi, he is always Reddi.
Friends, ladies and gentlemen, it's my proud privilege to welcome all of you to continuous, uninterrupted CME over last 21 years, number 974.
Sorry, just a second.
अभी रुक जाओ यार, इधर की मत बोलो, पोडियम वाली छोड़।
So, again, good evening to all of you and again, good evening to all of you and thank you. It's an honor to be here as always. And I was just thinking it's been more than now 2 decades of being here, and I think the group is growing. I see all the old faces here, and it's always good to see new people. And Dr. Bhaskar and Dr. Puja are no longer new people. They've been here for a while, but it's always a pleasure to be with all of you. So, I know this has gone on for a bit. So, I'm going to be talking about something which is very, very common. All of us pretty much see this every day. It doesn't matter which speciality you are. I mean, we think as neurologists, we see all kinds of patients, but I'm sure that physicians, pediatricians, ENT doctors, and then pretty much, I mean, you're an ophthalmologist, you name any doctor and somebody with the symptoms that I'm going to talk about today will end up. So, my talk today is going to be, it's a longish talk, I'll try and cut it down a little bit, but the whole idea is to try to help you understand how to approach a patient with a particular problem. And today I'm going to talk about, like I said, this very, very common symptom called dizziness. So you want the lights on? Lights on is better?
Light off. बंद कर दो light.
आप बंद कर दे बंद कर दे.
So, let me just start with this little spin that you see. And a lot of patients will just come to us and tell us that this is what they feel like. They feel like everything is going round and round. Some people will not be able to describe their symptoms properly, and I'll go through a lot of terms that are used by various patients when they're talking about the symptom. But before we get into a little bit about the symptom itself, a little bit about the anatomy, the basics. Now, we know that practically all symptoms arise in the inner ear. For this, this group of symptoms which comes under this, larger set called dizziness. And we have basically the bony labyrinth, inside which we have the membranous labyrinth. And we have the semicircular canals, which is the anterior, the lateral, which is also called the horizontal, and the posterior semicircular canals, which contain a small amount of fluid, which is called endolymph. And when this moves, it sends signals to the vestibulocochlear nerve to certain areas in the brainstem, through which our signals from the ear are sent, and this is how we perceive motion. So we have the otolith organs, which is the utricle and the saccule, and then you have the semicircular organs, which actually are responsible for all the signals that go from the inner ear to the brainstem. Now, these two organs, the otolith organs, which are called the utricle and the saccule, they are oriented in such a manner that they actually perceive certain types of motion in the head. The utricle is largely horizontal and registers accelerations in the horizontal plane. So if you have anybody moving like that, that is what the utricle will register, and the saccule will register movements in the vertical plane. So these two organs, along with the semicircular canal, are the ones that are responsible. So this is kind of summarizes that. You have the semicircular canals, which, like I said, the anterior, the horizontal, and the posterior, which are responsible for us to perceive angular head acceleration, and the otolith organs, which are for linear head acceleration. So true external vertigo indicates an abnormality of the semicircular canals, or their central connections that process these signals. Sometimes the sensation of flipping or tilting can occur with the otolith organs also. So, the vestibular organs are basically paired structures. The central nervous system receives signals from both sides and they sort of collates these signals. In a stationary head, there are tonic discharges coming from both sides, so we don't feel this sense of movement. But the moment we start moving our head in any direction, then these are alternatively, depending on which side, the right or the left, will be excited and inhibited, and this is recognized as motion. So, if you look at this particular symptom, I think this is an understatement, and this is a study that showed that even in the emergency, about 4% patients actually come in with dizziness. I think it will probably be much more than that, and it's thought that about 3 to 5% of those are because of stroke. So, stroke is not, it's still a smaller percentage of all the patients with dizziness, but it's still a very important, especially for neurologists, it's a very important thing, and we can't miss that. So this results in a lot of people getting a lot of tests, there's a lot of imaging, the length of stay in hospitals is often increased because of misdiagnosis, so it's important for us to approach these patients correctly and make the correct diagnosis. And most of the time, if you look in the emergency, patients whose strokes are missed are people who've come in with dizziness. And we don't have a lot of data in OPD, and that would depend on what kind of practice you have, where you're practicing, and the number of patients you see. But I'm sure that on any given day, a person who sees, let's say, about 15 or 20 patients a day would have at least 3 or 4 or 5 patients who complain of dizziness. So that's the least I would imagine that, and I think all of you would agree with that after years and years of practice. So it's important to make a specific diagnosis. In spite of all that, sometimes in practice we don't truly make a clear diagnosis. And misdiagnosis often results in a lot of costs to the patient. So it's important for patients to see the doctors who are actually trained in this. And this is a study which showed that in 3,400 patients who were over the age of 70, an accurate diagnosis was made in 3 out of 4 patients. So it's not that hard, even in the elderly patients, that you can make a correct diagnosis. Now, interestingly, this is one of those conditions in which our clinical senses really help us a lot. So it's important to have a careful examination of the eyes, the ears, the cardiovascular system, the nervous system, as well as the vestibular. These are the 5 things that you would like to look at in any patient who has this particular, let's say, falls under this rubric of dizziness. A proper history and a good clinical examination can provide a diagnosis in a majority of cases. Now, I'm going to come to this word vertigo, and this is also bandied about and misused by a lot of us. So what is vertigo? And vertigo is defined by the Hearing and Equilibrium Committee of the American Academy of Otolaryngology, Head and Neck Surgery, as a sensation of motion when no motion is occurring relative to the Earth's gravity. That's the definition. But I tell people, it's a sense of rotation of self or the environment when truly no movement is happening. You get the feeling you're spinning or the room is spinning, when actually no movement is happening. That is what vertigo is. So vertigo is a true sense of rotation. When a person tells us that he feels he's spinning or the room is spinning, there must be that quality in his complaint for us to diagnose vertigo. But other than that, a lot of patients are going to use all of these symptoms. They're going to say that they're lightheaded, they're faint, they're off balance, sometimes they complain of clumsiness, an inability to concentrate. All sorts of vague, words are used. And I'm talking about just in English. But if a person is going to speak to you in all the languages that we have in our country, then you can imagine the number of descriptions of this particular symptom. Punjabi, Hindi, and all the South Indian languages. I can't tell you the various kinds of description of the symptom I've heard from people. But I want to tell you that it's in the past, we used to approach all these patients with what was called a quality of symptom type diagnosis. So we did this for years, and I'll just tell you historically this was what was done. And in this, what we did was, we divided patients largely into 4 groups. We called it like flavors of ice cream. You had vanilla, you had strawberry, you had chocolate, and whatever else. So if a patient complained that he was feeling like he was going to faint, it was largely cardiovascular disorders, and we looked at all these orthostatic hypotension, etc., which is listed there. If a patient said that he was going to fall, we thought it was disequilibrium. A lot of these were thought to be because of cerebellar disorders as well as conditions which affected the brain mostly. Then you had a true sense of rotation of self for the environment, which was called vertigo. And here the patients could be divided into peripheral and central. And then of course, even in that peripheral it would be cochlear or retrocochlear pathology. And then these rather vague symptoms that I'm feeling a little lightheaded, I'm a little dizzy, and these were what we thought was psychological or psychosomatic patients who presented with these symptoms. But what was the problem with this? This has been the type or the way to diagnose patients, this so-called symptom quality or type approach, where you have these 1, 2, 3, and 4 types of, division into these 4 types of things. This has been going on since 1972. So, I mean, that's a long time ago. And so, this required a rethink because we felt that over the years, patients were not being diagnosed properly using this kind of paradigm. So now we use something called a timing and trigger approach. So this is how we classify vertigo. This is where I want to tell you that this is how we approach anybody who comes with these symptoms. First of all, like I said, patients are going to come, they're going to use vague words, they're going to try to establish whether this is truly vertigo or not. And then, depending on when you put them into a particular category, this is how you approach the patient. So you have first an acute vestibular syndrome, and then you have so this is a patient who comes in and he just comes in with acute dizziness or vertigo, and it's called an acute vestibular syndrome. And then you have what we call episodic vestibular syndrome, which can be either spontaneous or triggered. Now I'll tell you a little bit about this. An acute vestibular syndrome is actually something when a patient comes in with, when he's continuously dizzy, this may last days, he has nausea, vomiting, he may have nystagmus, he can't tolerate head motion very much, he has sometimes unsteadiness of gait. And the benign causes include vestibular diseases as well as sometimes serious causes like a posterior circulation stroke. A spontaneous episodic vestibular syndrome is episodic dizziness which is spontaneous. So this includes things like vertiginous migraine. It comes over a few days and this is not something which is being triggered. And triggered is our canal diseases, what we call our benign positional paroxysmal vertigos, and those are the prototypes of that. And this is typically somebody who comes and tells us that I'm fine, and when I turn my head, I suddenly feel I'm spinning. So that is called a triggered episodic vestibular syndrome. So I'm just showing you in the emergency what happens. Most of these people, if they come with their first attack, even if it is spontaneous episodic vestibular or a triggered, you have to treat it as the first category. That's the first thing. You say that this is an acute vestibular syndrome. They could have symptoms at that time. They'll have all these vegetative symptoms like nausea, vomiting, all these things will be there. And this will be there during your assessment and over a period of time it wanes, as you can see the graph there. The moment you get it lower down, you look at that spontaneous episodic or triggered episodic, most of these people are not very symptomatic at baseline. But they would have all these other symptoms and it will come and go. The thing about spontaneous episodic vestibular syndrome is that the symptoms when they come on, they usually last for much longer. Triggered may, the patient turns his head and he gets a feeling he's falling off the bed, he will scream, he will shout, he will grab the bed and he will want to close his eyes and lie down again. So you can see those little spikes there and the lower portion of the spike will tell you how long these symptoms last, and you can see that triggered episodic is just like a spike that goes up straight and comes down. So this is how you actually approach a patient who is acutely dizzy. The first step, you look at an initial exam. If it shows obvious neurological findings, then you don't have to worry about anything. You initiate a local acute stroke protocol, which is in our place we call it a code stroke. So when I say that, a patient's come with dizziness, has a clear facial paresis, or he's got one side he's weak or something like that, then there's no question of going anywhere else and going ahead with this protocol. Suppose that is not there, what would you do next? You will look at the clinical evaluation. Now let's say that you examine him and you find out that he has, let's say, a heart rate of 24 or his sugars are 22. And then you don't have to worry about anything else. You say that, look, this is because that, you stop it, you don't do anything further. When you do that, you also look at any neurological signs and symptoms. You say that is there any nystagmus which is pathological, is there any incoordination of the arms or legs, is there any truncal ataxia? If that is the case, you will treat the presumed diagnosis. Now, if none of these things are there, you go into the third step, and then you start those three things that I told you about, whether it's an acute vestibular syndrome, is the dizziness triggerable? If it's triggerable, then it's a triggered episodic vestibular syndrome. If it's not triggerable, it's a spontaneous. This is a very simple sort of table to look at, and via this, you can actually diagnose pretty much anybody who comes into the emergency or even into the OPD, and you must do all these. Just go through this table, it's not very hard to do. Now, I want to tell you that most people who come, how do you truly differentiate a triggered? A triggered means that a patient is not dizzy at baseline, or he's not vertiginous at baseline. So he's fine when he's sitting and talking to you, but let's say he's got benign position paroxysmal vertigo. He turns, he does some position which triggers that, and he will become sick immediately. Most people with acute vestibular syndrome will have some dizziness that gets worse by movement. That is different from a person who is triggered. So please understand the difference. One is I get triggered, and somebody who is already having symptoms who gets worse with head motion. So most people who have any kind of disease related to vestibular syndrome system or their connection will invariably get worse with head motion and all that. But that is not a trigger. So there's a difference between these two. Now, how do you approach these patients? So, how do you do what is a clinical exam to try and differentiate all these? I'm going to show you this. This is called hinge. I'm sure that, Dr. Bhaskar, Dr. Puja Narang will be very familiar with this, but I'm sure all the PhDs will. But this is also something that can be done bedside. When we talk about the hinge examination, this is clinical examination of a patient who's come in with dizziness or vertigo to the clinic. Hinge is head impulse, N is nystagmus, TS is test of skew. You do these things to try to differentiate whether it's a central or a peripheral cause of the symptoms of the patient. So what do? You look at gaze testing for nystagmus. You do something called a test of skew. You do a cover test, which is an alternate cover. You cover the eyes. I'll show you a video of that. And you do a head impulse test also to figure whether this is a central or a peripheral process. So I'm going to start with, so when you look at this hinge, nystagmus is right in the middle, and you would want to start with the head impulse and then go to nystagmus and then do the test of skew. But nystagmus is the easiest to do. Patient comes in, you don't have to do anything, so you start with that first. It's less intrusive, you're not asking the patient to do anything fancy. If you don't have nystagmus, the chances of it being vestibular neuritis is very unlikely. So always when you're making a diagnosis of peripheral vestibulopathy, understand none of these are absolute rules, but I want to tell you that it's unlikely that if a person doesn't have nystagmus that there is any vestibular. Also remember that a lot of patients are coming to you while they've been given some medications by someone else, and hence there could be some suppression of the nystagmus. And most of the nystagmus could either be primary gaze or gaze evoked. So you have to look at primary gaze and ask them to look left and right to see if the nystagmus is on looking to the left or the right. Now, I'm going to just tell you that there is a lot of differences between nystagmus, which is either peripheral or central. But broadly speaking, I just don't want to confuse you because there are exceptions to everything. Peripheral vestibular pattern is usually unidirectional, horizontal and spontaneous. There is a latency, it can be a latency of about 30-40 seconds sometimes, and there's fatigue of it. Whereas central vestibular patterns are usually, they are bidirectional. If you have a vertical kind of pattern where there is a purely torsional pattern, there is a gaze evoked pattern. If you look to the left, look to the right, if you're having this kind of nystagmus, then it's more likely to be central. So you need to understand that there are exceptions. Now, I won't go through this, just to tell you that depending on what kind of disease we are dealing with, there are different types of nystagmus, be it central or peripheral, and there are exceptions to both. Now, so we've done the nystagmus, we've looked at the nystagmus, we've tried to differentiate basis the nystagmus, whether this is a peripheral or central type of condition that we're dealing with. So the next thing we do is what is called the test of skew. So here you'll see this. I hope the video plays. Yeah. Now look at the patient's right eye. And you will see a little vertical movement of the eye when he's correcting. Can you see that? Yes. So that vertical correction is what you see in patients who have a, let's say, a central cause of these symptoms. If a person can, it will not occur in peripheral disease. A horizontal correction is not acceptable. You have to have a vertical correction, and I'll show you that again if I can. I hope it. Now look at the right eye. So this is a cover-uncover test. It's called the test of skew. And you see the right eye correcting. You see that vertical correction? So this is the second part of the hint. We did nystagmus, then we're doing the test of skew. Okay? So if this is there, this suggests that this is a central cause and not a peripheral cause. The next is what is called the head impulse test, and I'll show you that again in a quick video, again hoping that so you see this, you ask the patient to fix and hold the head. You have to have somebody else holding a thumb or a finger there, and you can ask her to keep looking at that finger and jerk the head to either side. Now when you see here, you see that video again, I'll show it to you again. When the person is fixing, and when you move the head, the eyes will remain fixed if the patient has a good vestibular system. And the moment it's not good, the eyes will move and the correction will come back. You will see a corrective saccade. A saccade is an eye movement which happens. And you will see that, now I'm going to ask you to look at that again once. And just look at her eyes. This is the correction. Here it is normal. Now she looks to the right, it's normal. Right? Now you look to the when the head movement occurs in the other direction, you see a corrective eye movement. Now it should be normal. You see the difference there? So that correction that happens tells us that there is a pathology on that side. Again, I'm so sorry, I'm going to just force you to look at this once more. Just to appreciate it. I know that that's the correction. This is normal. See? There's no correction of the eye. Here again you see a correction. Alright? So that's how, so this is called a head impulse test. Now I want to tell you that if you have a head impulse test which is positive, it means a peripheral vestibular disease. A central cause will have a normal head impulse. There will be no corrective saccade. So it's important to understand if a patient does not have, so head impulse test being normal, it signifies a more serious pathology. Whereas if this is there, it signifies a peripheral disease which is very bothersome to the patient, but in generally not so worrisome. Okay? Now all this is happening, we have the hints. I'm going to just extend that to hints plus, where you look at targeted neurological testing. You start examining the patient more closely to look for any kind of neurological disturbances which might suggest that this is central cause. You make the patient walk. And when you're doing all this, you can see that there is always going to be exceptions to the rules. But I think it's important to understand that every time we treat a patient, we don't have to keep looking for exceptions. See, by and large, when we're in private practice, and I'm a little ashamed to say this, we end up doing imaging for everybody. You're going to be very careful, you don't want to miss anybody and all that. But at the end of the day, if we look carefully in most patients, you will be able to make a diagnosis. And this, like I said, the hint plus and just the examination of the patient is enough to make a diagnosis. Now I want to tell you that when I'm showing you this table again, you have the nystagmus test of skew, head impulse test, target neural gauge, and truncal ataxia. A central cause can occur even if any one of these are there. That means it is a central problem. In 5 में से एक भी हुआ, so you are dealing with something in the brain. For proving that it's purely vestibular problem, you must have all things positive. If you have 4 out of 5 positive also, you might not be 100% certain, but to understand that even if one of those things shows that it is towards the central, it is likely to be central. So this is something I need for you to understand. So to just tell you that if you have these eye signs, there are 3 dangerous subtle oculomotor signs which suggest infarct. In is if you have a normal head impulse test, if you have a FA which is a fast phase alternating nystagmus, and if you have a refixation, a vertical refixation on cover test, on the test of skew, infarct is what you need to remember, that these are the 3 things that tell us that this is a central cause and this would be a worry symptom. I want to tell you how sensitive it is. People have done a study where they actually compared this to MRIs, and they found that if you have a normal head impulse, if you have a direction changing nystagmus in eccentric case, as well as a skew, if you look at all these 3 things, this was more sensitive than MRI in picking up posterior circulation. So this was at 100% specificity and a 96% sensitivity. And when they compared this to the MRI, and this was the MRI that was done within 48 hours of a patient coming with these certain symptoms, the MRI missed about 12% of these patients who had stroke, whereas this did not miss that. So the clinical examination in this particular study was actually better than an MRI. And I want to tell you, MRIs, when they do miss strokes, they're going to miss posterior circulation stroke. And if you look at the sensitivity of MRI, they would miss about 7 to 10% of all strokes on average. If a patient comes with clear stroke symptoms within a window period also, apart from the fact that it takes time for things to evolve, even if you do it after a certain time, posterior circulation strokes can be missed. And that is 5:1 compared to anterior circulation stroke. So now, I'm just going to briefly talk about this because I think this is, a little beyond, this is an entire talk by itself for how to manage patients who have inner ear disease related to the ears. In the sense because of what we call a triggered episodic vestibular syndrome. And I want to just tell you here that I told you about the 3 semicircular canals. I told you there's a posterior, there's an anterior or superior, and there is a horizontal or lateral. Now, the commonest cause of benign positional paroxysmal vertigo, about 80% patients are going to be posterior canal. So, even if you do the Laplace for everybody, you're going to get it right 8 out of 10 times. Okay? Laplace is a corrective procedure for this. And then if you're talking about a horizontal canal and the anterior canal, I'm not going to go down into details because I'm going to show you a quick video about this, and Dr. Prasha and the others can just help me out with this. Here what you're doing is, and I'm going to show you a video again, don't do these procedures in patients who have a lot of cervical pain, who have, let's say, ankylosing spondylitis, or if you think that there's any neck pathology which can cause an issue, don't do that. Don't do it in patients who can't lie down flat. But I'm just going to show you the video. Can you hear this?
Sir, अपना mic भी डालना है.
Head is turned 45 degrees and his body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. Eye twitching that rotates is called torsional nystagmus. Side-to-side eye twitching is called horizontal nystagmus. Eye twitching that goes up and down is called vertical nystagmus. The Dix-Hallbeck maneuver is then repeated on the opposite side. This maneuver should be repeated several times to document for fatigability. When performing this maneuver, another individual can help. Please note that feeling dizzy but without nystagmus is not considered diagnostic for BPPV. Eye twitching must be present for BPPV to be diagnosed. Rotatory nystagmus indicates posterior canal BPPV for which the epic maneuver is performed. Lateral nystagmus indicates lateral canal BPPV for which the Lepper's maneuver is performed. Vertical nystagmus indicates superior canal BPPV for which the deep head hanging maneuver can be performed.
Sorry, so I'm not going to go, like I said, into too much into this because, again, it's just another entire talk, and I don't want to keep talking about things which are channelolithiasis. Pupillolithiasis is much more common, and I think, this eyeball movement, I don't want to, again, not part of this talk. I think all you need to understand here is that when you're talking about triggered episodic vestibular syndrome, you're going to worry about mostly PPPVs, and these patients who come to you, they'll be usually much more symptomatic than people with a central cause. They're much more troubled by the symptoms, and they keep having. It's easy enough to diagnose if a patient has been having this for years. If he comes to you and tells you, look, it has happened 5 times in the last 2 years, then you're much more relaxed. But these people, it's the first event when a patient comes to you that you always worry. Now, what are the aims of vertigo management? So, first of all, you try to diagnose the cause, not merely suppress symptoms. You try to restore normalcy to the deranged balance function by promoting vestibular compensation through physical therapy. And I'll talk to you a little bit about that. And you want to provide symptomatic relief with vertigo as well as antiemetic drugs. So these are the commonly used medications. I want to tell you that typically what I do is I use the prochlorperazine as an antiemetic right in the beginning for all these vegetative symptoms. I sometimes use benzodiazepines, and I predominantly use beta-histine as my go-to. Not because I'm here because of beta-histine, but really those are the ones that I typically use. So this is the options. Like I said, prochlorperazine I start with, I give beta-histine. I usually give beta-histine for a fair bit of time. I'm not one of those who give it for 10 days or 2 weeks. I give it for much longer. Most patients would be given this for a period of usually 6 weeks, and this is for symptomatic relief predominantly. Now, you provide symptomatic relief, which is very important. If the patient is not comfortable, if he's not relieved from the symptoms, he's going to go somewhere else, he's going to try something else. By and large, the immediate medication such as prochlorperazine is recommended for about 3 to 5 days. I've told you earlier, detailed examination is often required to make a diagnosis. You use antiemetics to try and, again, suppress the symptoms, the best vegetative symptoms. You put the patient on something like beta-histine at that dosage, again, depending on the duration, you can use it for up to 3 months. You start the patient on vestibular rehab early. And I'll tell you this because a lot of times patients are very uncomfortable, they don't want to do anything. But you want to not let them get used to not doing anything. If the moment your body adapts to a particular position, then you will have worse symptoms when you try to get out of that. So this is just vestibular compensation. I'm not going to go through all this in detail, but just to tell you that, there's these exercises which we talk about, and there are the bunch of exercises. Again, this itself, vestibular compensation itself will talk, is that, in the Second World War, a lot of these soldiers who had concussion of their ears because of bomb blast injuries, and they were acutely vertiginous. Cawthorne and Cooksey actually noted that people who got off the bed quicker did better in the long run. So they say that you get out of the bed quickly and you start these exercises as early as possible so that you don't maladapt. That is the whole thing. And again, the ways that it works, in fact, what this particular drug beta-histine does is that it increases the histamine there, and increasing the histamine at that level of the vestibular nuclei actually helps with vestibular compensation. It takes about 3 months for this to happen. And you have all these different types of exercises. There's a very good app called Vertigo Coach. It has 11 videos. And this is an app by Apple. It's a free app. It's there in 6 languages. I always share it with all my patients. They're very, very simple videos. Each of these videos is about 45 seconds to a minute. And you just tell them that, look, this is the app, download the app, do these exercises. And doing these exercises, any form of vertigo actually gets better. That's what we've seen. It's not even bad for, you want to do these maneuvers for all these patients with the benign positional paroxysmal vertigo. You have to do the maneuvers, whatever maneuver you choose depending on the canal. After that, to try and maintain them, you can continue to have them do all these things at home. And there are a lot of exercises and this and that. So, just to summarize, by and large, you want to make a correct diagnosis. The first thing is, I told you, clinical examination, making sure that you do the hinge examination, you do the hinge plus, you make sure that you have a diagnosis between central and peripheral. If there is a doubt, please image and make sure you're not missing anything. But I've told you that good clinical exam, there are studies to show that a good clinical exam is actually more sensitive than MRI also. So this is something I want to tell everybody here. Don't underestimate our clinical sense. So even when you look for pallor, and I don't see a lot of people examining people to look whether they are anemic. Even that can tell you or give you a clue whether the patient is dizzy just because of anemia. So there are so many. There's a great. I mean, we achieve a great deal with a good clinical exam. So like I said, there's a lot to be talked about in this topic, but I thought that I'll just go through this. Dr. Bhaskar, Dr. Puja Narang are here to sort of fill in the gaps that I missed today, and I want to thank you all for being here.
लाइट जला उधर की भी जला दे.
It's a wonderful talk, sir. I would say mesmerizing, sir. First to my moderator, Dr. Bhaskar Shukla, to set the context for the meeting and the question answer session.
So wonderful talk, sir. You covered everything, and a very nice approach how you tackle a patient who comes to the clinic with a complaint of dizziness. So the same word as sir said, dizziness can mean different for different patients. So we have to really inquire in detail what exactly he or she means when he says that he or she is dizzy. So it can, at the same time, it can mean a true vertigo, true spinning vertigo. It can mean a sense of disequilibrium, or it can be some psychogenic dizziness, and so forth. So it is very important to first ask very carefully and do appropriate clinical examination to localize the symptom of dizziness. So while making a diagnosis, we have to factor in the commonality also. How common is the condition in a given clinical context? Say for example, if a female patient comes and if it is not it is episodic and it is not a triggered vertigo, as I said. So we should definitely think about vestibular vertigo, which is a very common condition. Sometimes the patient will only complain about the vertigo and not the headache. So it is important not to miss out on that, and equally important, especially when elderly is coming to the clinic with the vascular risk factor. So we should not miss out on the central causes of vertigo. HINTS is definitely a very useful clinical examination tool, and if used appropriately, it is much more sensitive than MRI assessment. So nothing more to sir, only comments, nothing more to ask sir. Very wonderfully.
Dr. Puja, ma'am, your take on the talk, the wonderful talk Dr. Rajashekhar Reddi has taken.
Thank you so much.
Specifically, I would like to ask you, for my physician friends, how to differentiate between central vertigo and peripheral vertigo. What is the pointer?
So, starting from the clinical symptoms, that remains the basis for all the kind of diseases we deal with. So we have to focus on the symptoms that apart from giddiness or whatever the symptom, whatever language the patient is describing the symptom of dizziness, what associated symptoms the patient has. So if we clearly find out that there are other associated symptoms of facial deviation, hand weakness, numbness, then we know that we are not dealing with a vertigo and we are dealing with something central going on. Second thing is cranial nerve examination apart from the limb assessment and all. Suppose if the patient has associated only hearing loss, no other neurological deficit, then we know that it can be central as well as peripheral. We need to take out more of the history in that case. And apart from the clinical symptoms, I think we need to focus on the comorbid conditions also. So age and gender of the patient along with the comorbid conditions. So suppose anybody who is diabetic, hypertensive, aged male with cardiac history, AF going on, then on those patients, giddiness cannot be, we cannot just miss the diagnosis of stroke in those. We have to keep a high suspicion even if the vertigo is being described as positional vertigo. So those are based on the clinical history, and then comes on the examination part. Then we know that this hints test, it helps in distinguishing, and we have to focus on the types of nystagmus. Because nystagmus, if vertical, points to the central cause. If it is unidirectional, horizontal, it points to the peripheral cause. So that's how we have to differentiate. And there are some red flags in a case of acute vertigo case. So anyone who comes with severe chakkar hai, sudden onset hai. So apart from the symptom, there are like if a patient has severe headache associated with lot of vomitings, deficit neurological examination पे deficit मिल रहा है. So there are the red flags. We need to image the patient. Nystagmus vertical मिल रहा है. In those patients, we have to go for MRI as soon as possible because high possibility of stroke is there in those. Because as we have been told that peripheral vertigo is more symptomatic, so patient will make a lot of noise in the OPD and emergency that बहुत चक्कर आ रहा है, but those are kind of benign. And stroke are the things which do not give us much time, especially in the posterior circulation. So we have to keep a high suspicion in those cases and image as soon as possible.
Dr. Rajashekhar Reddi sir, I would like to know specifically from you sir, stroke can be anterior circulation, it can be posterior circulation. I understand that vertigo, dizziness is actually more common with posterior circulation strokes.
That's right.
Sir, what are the red flag signs that we must refer the case to you when we get a case of vertigo? You beautifully demonstrated positional vertigo, and I often see Dr. Parashar telling me, Sushil, don't worry, it is benign positional paroxysmal vertigo. Sir, how do we identify as clinicians in our OPD? We are not trained neurologists, we are physicians. Sir, what are the minimum neurological examination that we should do? I understand any loss of power, any loss of coordination, and a positive baby's kiss sign. If they are there, refer the case to Dr. Reddi immediately. So, sir, according to you, can you educate me more regarding the red flag signs when I should be very vigilant and not take it lightly?
So, John, I think very good point you made already. But I think one of the things is that first of all you have to see whether this is the first time the patient has had a symptom or not. The easiest is if a patient tells you that I've had this 10 times in the last 5 years. If they tell you that this has happened many times in the last few years, then you are very less likely to have a stroke in that patient. Obviously, the same symptoms can't be recurring repeatedly for years and years or something like that. And some people will come and tell you that this is exactly what happened to me 5 years ago, 7 years ago, I had exactly the same problem. So your level of anxiety then tends to fall a little bit and you say, okay, this is probably just a peripheral. But sometimes it's difficult to examine patients. They're so fearful of even doing anything that it's not the easiest to examine. But if a patient says, like Dr. Puja clearly said, that if a person has other neurological signs, so you're looking at the cranial nerves, then you're looking at any symptoms related to that. If there's dysarthria, there's a slurring of speech. I mean, if there is any kind of dysphagia, the patient starts complaining of excruciating headaches during this. So all those symptoms are going to be red flags, right? By and large, peripheral vertigo is actually more distressing to the patient than central vertigo. Central vertigo is thought to be more mild and constant with exacerbations, but peripheral vertigo is just it comes and goes. I want to tell you that isolated vertigo being due to the brain is not common. So isolated vertigo. So if a patient comes with isolated vertigo,
only vertigo as a symptom.
As a symptom, then it is less likely to be brain related as compared to young vertigo. So nothing is impossible in medicine. Medicine is easy except for the exceptions, what we've been always taught. But by and large, if you remember that if the patient only has vertigo and no other symptoms at all, it's unlikely to be central. That's what you've got to remember while examining this patient.
Dr. Rajashekhar Reddi sir, I would like to ask you a very pointed question for the benefit of everybody in the audience. Sir, there is a condition called vertebral artery dissection. and it can also present only with vertigo. Sir, what is this condition and when should we suspect this condition in our patients? Kindly educate us.
Sure. So, see, again, like I said, by and large, when you talk about vertebral artery dissection, many patients will give history of neck pain. So there will be a patient who will tell you that I did some yoga, I did some unusual neck positions, started having severe neck pain. These are usually younger patients who have vertebral artery dissection. And because there are 4 segments of the vertebral artery, V1, V2, V3, V4, the first and the fourth, which traverse bony foramina, are the ones that are most prone to dissection. Second and third are more prone to thrombosis. So when they dissect here, they usually pain. And apart from the vertigo, they will typically have other symptoms also. If you examine closely, it's unlikely that a patient. But first thing is that there is pain, neck pain, and after that dissection. I've had a patient who had vertebral artery dissection who was from Oscars, who was playing badminton. So he extended his neck backwards. And while he was doing that, he found severe pain. And after the severe pain, he started having vertigo, and then he started having other brainstem signs, came to the emergency. So there will be history like that. I don't want to, there are yoga gurus who do stuff, and after a camp of theirs, there will be 3 patients who will come with so neck manipulation, a barber jerking your head suddenly. So all that history comes as important. I mean, again, this is a cause for posterior circulation stroke. So you would imagine that you would get symptoms of posterior circulation stroke with vertebral artery dissection. Other symptoms would be there. Suppose it's a lateral medullary syndrome, secondary vertebral. Then you examine, they will have sometimes a honor. They will have so many other symptoms. Numbness on one side of the body. Typically they will have.
Sir, another question. If suppose you diagnose a case as vertebral artery dissection, what do you do in your setup, sir?
So the good thing about vertebral artery dissection is that in an acute setting, once you have these patients, whether you should lyse them, suppose they come in a window period, is a tricky question because...
What do you lyse them with, sir?
No, when you
RTPA?
You can use, now we use tissue...
100 milligram?
It's 0.9 mg per kg for TPA, and for tenecteplase it's 0.2 mg per kg. So
Are they both effective?
They're both effective. I'm talking about stroke. Now let's not make it vertebral artery dissection.
I'm talking about stroke only, sir.
Both are equally effective, and very recently there have been, maybe about 2 weeks ago, there have been approvals for 2 more drugs which are not yet available in India. But there's a drug called Retaplase and a pro-urokinase, which have both been approved for IV thrombolysis now by this thing.
Sir, I wanted to ask you, suppose we get a case of vertebral artery dissection, we refer it to MAX, diagnosed as vertebral artery dissection. Do you have a 24/7 interventional neurologist available?
Yes, we have.
You have, sir. You have. Sir, how much does it cost to treat these cases, just for the benefit of everyone in the audience?
Not all vertebral artery dissection are going to require any intervention.
Yes, sir.
So you don't have to do treatment. Many of them will just going to be managed with medical management. And like I said, if you have a dissected vessel, whether you should lyse them or not becomes sometimes controversial, because if they have some degree of bleeding as a result of the dissection, that can also be a contraindication to do lysis. But that is a decision which is taken at that time. And most of these people, they will go into the ICU for at least some period of time and into the stroke unit. And then they're out of the unit maybe 48 hours if everything goes very well. It will still cost around maybe about 2.5 to 3 lakhs by the time they're out of the hospital. All inclusive.
Right. Sir, 48 hours ago I was discussing a case with you of antiphospholipid antibody syndrome. One of my wife's Renu's batchmate from Mansi, who is now settled in US, and his wife got antiphospholipid antibody syndrome. 3 strokes. When do you start suspecting? In the first stroke, she was never diagnosed as antiphospholipid antibody syndrome. Sir, just a word of caution for everybody here, for a young patient with stroke, and because me and Dr. Renu saw her with lot of neurological deficits, she was not able to take a step on her own. Just kindly educate us. the basilar artery, the posterior circulation strokes. Just a word on that.
So, see, basically, young strokes, you will require more evaluation rather than the usual risk factors that we typically do. So, you will look at procoagulant stage, you will look at the workup for all that, and there are arterial procoagulant stages and got venous. So, protein C, protein S, factor V, and antithrombin 3 are all venous. Whereas antiphospholipid antibody syndrome and homocysteine and lupus anticoagulant are a little more arterial. I mean, they can occur in both, but little more arterial. So you do all that workup. There are other things like prothrombin G20-210 mutation. There's so many things that you can test for. But these patients will typically have an echo more, you look at a T, make sure there's no rheumatic heart disease that has been missed. If there is a patient who comes in with rheumatological disease, then you'll have to make sure that all the investigations for vasculitis are also done. And you want to make sure that rheumatic heart disease is not missed. So this patient, I think the concern was that she did not, in spite of anticoagulation, she was not able to maintain what is called a TTR, a time in the therapeutic range. So she was only doing that maybe 10% or 20%. So the question was whether we could put her on NOACs now, these newer medication. So as the indications evolve, there's never going to be a trial where they can do it for antiphospholipid antibody syndrome. But over the years, I think slowly we've gotten more confident. Now we use it for cortical venous sinus thrombosis. So slowly, when you have a difficult situation, you can use it. I think that was the about basilar artery disease and anterior circulation, posterior circulation that can occur in any form of stroke, whether it's young stroke or other stroke, all kind of manifestations can happen. So we even basilar artery thrombosis, we've had situations patients will come in with acute stroke. We will take them into the endovascular suite. We'll open them up. This can be done up to 24 hours easily. So patients who are progressing, who are getting worse, who have come in 8-10 hours also will go in. And today I'm discharging a patient who's the brother of a very senior BJP functionary. He's actually was the health minister of UP. His brother, real brother with posterior circulatory stroke, he was quadriplegic,
Sir,
0.5 power, age 67. And he's completely 100% okay. There is no deficit. He came with quadriplegia, locked in state practically, not moving anything, about 4 hours into a stroke. And we took him up, we did a procedure, and after that he's been on dual antiplatelets, he's been doing very well. So there are so many things, patients do well when they are treated appropriately and in time. I think time is the most important thing in stroke.
I'm sure there will be many questions. Before I go to my panelist and my moderator, Dr. L.M. Parashar, my ENT roommate from Maulana, I'm sure he can. ENT में मैं तो सर मेडिसिन में था, ये ENT में थे, तो ये बहुत बढ़िया डॉक्टर है ENT के, बहुत बढ़िया. इसीलिए काम में लगाए हुए.
Well, it was so clear by Dr. Rajashekhar Reddi that in vertigo management, the best thing is that we have to not miss the sitters, red flags. That is, don't miss a neurological event, don't miss a cardiac event. And of course, vertigo all of us can treat. As a practicing ENT surgeon for so long, all I would say is that of course, after having diagnosed that as peripheral vertigo only and to treat it, please give the proper dosages of Vertin. Almost everyone uses Vertin for this, but what I see, I'm ashamed of that people are using very minuscule doses of Vertin and therefore they don't get the requisite relief. So I request everyone to please use 16 milligram of Vertin 3 times a day for at least 14 days for your patient to be okay and remaining okay for time to come. Rather than just use 8 milligram OD, these are the kind of dosages which bring disrepute to the medical profession. Please don't do that.
Friends, we had felicitated Dr. Manoj Mehta, and I was so amazed to see a neurosurgeon who is an interventional neurosurgeon, because I always thought that neurosurgeons are interventionists. They always intervene. So your comment on the wonderful talk by Dr. Rajashekhar Reddi and your take on this.
Sir, very good presentation. So my take on it is simple. Stroke is like a bomb blast. Simply. So if we if we got a call from neurologist, then there is a stroke and there is a blockage, we open it up immediately. So my simple thing for the benefit of audience is, when you will say in the posterior circulation symptoms like vertigo and all, when you will say stroke is there and we have to do MRI and we give call to the interventionist, so that if there is a blockage, we open it up and the patient is improved immediately. So in a nutshell, what are the symptoms of those vertigo and all those symptoms that we suspect posterior circulation stroke?
We need imaging.
Imaging in MRI, we need in what cases? We should do MRI in those cases.
Dr. Rajashekhar Reddi is always not a very great fan of imaging. He is very rational. Sir, your take on the absolute indication for imaging in vertigo. Sir, there is.
So I think Dr. Puja really clearly said that, see, if a person comes in with these symptoms, has any neurological signs of any other sort, be it symptoms wise or signs wise, then don't hesitate, do the imaging. And so I personally don't do a lot of MRIs. Okay, to start with, when a patient comes in, my main purpose in stroke medicine is to rule out bleed. I do a CT head, I do a CT angio, neck and brain. If I see any LVO, I'll take them up for a procedure if they're within that window period. Now, I don't wait, I will live and I will take. At worst, what will happen is that the DSA will be normal. There's no big deal. People are often concerned that if you take up people with unknown creatinine and you do a CT angio, then you'll affect their kidneys. The rules are neurons before nephrons. Very aggressive people in the US and all that who say that if you have a patient with a stroke and if he's going to be on bed all his life, the kidney you can transplant later. I mean, they go as far as to say that. I mean, I think that's a bit much, but I mean, no, but that's as far as that. So the whole idea is that in stroke medicine, you need this. MRIs, when do I do an MRI? I do an MRI when I have a wake-up stroke. When I don't, so many people with stroke medicine believe that MRIs waste time. So even if you do very quick protocols, it'll still take about 15 minutes to get a patient. And the patient has to cooperate a fair bit to be in an MRI machine. So it gives you more information. And as MRIs evolve, as the technicians get better, then you can maybe do MRIs in those suspect cases. But for me, I'll do it when I have on the border of, out of window period patients who've come in 8-10 hours. And those are the patients that I'll do with MRIs. If a patient can't cooperate for an MRI, there are studies to show that he has a large stroke or a bleed. So if a patient is very restless, he's moving around too much, he's not able to lie properly, or he can't get an MRI done, it usually turns out to be a bleed or a fairly large stroke. So there are certain things, but I prefer CT. I go with CT for most patients. I know that posterior circulation you don't see very much. There is a posterior circulation or aspects also in which you can actually, there's a PC aspects of it where as but I think, the more you make it complicated, the more problems happen. So you've got to try and keep it as simple. 95% you'll manage. 5%, those guys, whatever you do, they don't do very well. So you have to make the ones you can get better.
One question. Dr. H.L. Kandru, sir, the youngest student at the age of 17 years from Physician Forum.
Ma'am, you are saying that central vertigo is due to the anterior movements of the distinct movements. So what is the rationale behind and why 85% of the vertigo, central vertigo is due to the posterior semicircular canal disturbance? Just dilate about these things. Why?
So, see, basically, if you look at these semicircular canals, the way they're anatomically oriented, the posterior semicircular canal is the lowest. So when you're talking about the pathology between this is thought to be autoconia. There's debris in the ear. So by gravity, it tends to settle in the lowest part. So the most affected is the horizontal semicircular canal. Because the posterior semicircular canal, the horizontal or the lateral is like that, anterior is on top. So the least is the anterior or the superior. You will get 1 to 2% of all benign positional vertigo as a result of the anterior superior. About 15 to 20% because of lateral or horizontal, and 80% because of the posterior. That's just the orientation of the canals. That's how it is. What is the other question, sir?
The question, why the central
view, but I think you're just being generous, and I've been 21 years now, so it's been a long journey with all of you, and I've enjoyed every evening here. Thank you so much. Thank you.
So, prolonged use of vestibular suppressants, Dr. Alan Parashar talked about. So, this can cause a chronic vestibular imbalance. You said probably use it for 3 months. I remember in one of my patients, you are continuing with this drug, the Vertin, for maybe about 8 years now. So this patient is of course a patient of SLE, Amanpreet Singh, you would probably recollect that. So you could use these drugs for a long time.
Absolutely, sir. So a lot of people, and when they take these drugs off, they start feeling very uneasy and uncomfortable, and sometimes we just continue. And there isn't a great deal of evidence now. Neuro-otologists, there are a couple of them who come to India a lot. There's a gentleman called Michael Stroop who comes, and he has used 540 milligrams.
Absolutely.
So he keeps quoting that case of his, and he says that apart from sedation, it doesn't do anything very much. So it's a safe drug, but we must remember that we try to get patients off medications as much as we can after we think that it's not required. But there are patients who are only comfortable on that medication. It's like some people who take, for instance, a benzodiazepine and they've been taking it for 40 years. And I don't intend to try to stop them. It doesn't make sense to want to do it. Or sometimes we have a patient with a juvenile myoclonic epilepsy who's well controlled for 20 years on phenytoin or carbamazepine. You don't want to change it because it's like that.
Yeah. So the commonest cause of vertigo is probably BPPV. And the second commonest cause appears to be the VM. How often are you seeing VM in your clinical practice?
So vestibular migraine as such is, so many people with migraine symptoms will also complain of some vertigo. So some people talk about it, is it a separate disease entity by itself? So I think that you need to understand that when you talk about vestibular migraine, their predominant symptoms should be vertigo, and then the headache is sometimes an afterthought.
Headache may or may not be present.
Headache is a little bit, the headache is invariably there, but it's not the overpowering symptom that bothers them.
Right.
Whereas most people who are migraineurs will complain of some sense of discomfort when they move their heads, they have photophobia, there's so many other things happening.
So how do you treat these patients? Lifestyle modifications and then vestibular suppressants, and what is the role of CGRP here?
So see, all the CGRP antibodies, be it, so there are now, we have these monoclonal antibodies. We have only one in India, which is called Erenumab. It's called Suviri, which is once a month. We have another 3 which are approved worldwide: Galcanezumab, Eptinezumab, and Tremelimumab. Those are not available yet. They are going to be efficacious for all types of migraines. So they are good drugs, but they are expensive at home. Now you have GPANs also which are available now.
My last question would be regarding what is the etiology of vestibular migraine? Do we know?
See, migraine itself is an interplay between your genes and the environment. So a lot of times when people come to us, why they have specifically vestibular migraine is hard to say, but I would imagine that they probably have some other causes also which are maybe aggravating these vestibular symptoms.
Abnormal activity in the vestibular probably system?
Correct.
Thank you, sir.
I'll tell you a very interesting case. A patient came back from out of town, and she came back from the hills. She reached home at about 8 o'clock. She had dinner and went to sleep, and then got up at about 1 o'clock in the morning with severe dizziness, vomiting, nausea, nystagmus. And they rushed her to Max Gurgaon, where they did an MRI, and the MRI was normal. This was about 3 months after onset. Then they transferred her to my care, and they reached my hospital about 7:38. The family brought her. So she looked pure. She had every symptom that you could think of in posterior circulation clinically, and the MRI was normal. She was out of the window. So I said, look, it's so much happening. I sent her back for another MRI in my place. It's about 12 hours after. And the MRI was clean again. And there was nothing at all. So I said, look, this could be a vestibular migraine, and that's the only thing that we worry about. And anyway, we're treating for stroke and this and that. So the family goes back home in the evening, and the help has escaped, has robbed them and left the house, and he had put something in our food. And it is probably some sort of sodium oxybate or whatever else, which is odorless, or whatever drug, we don't know that. But she had pure symptoms of posterior circulation stroke. And I still remember this because both these symptoms, both these MRIs came back as normal. And I had a hard time telling the insurance ki kyun karaya? Okay, the first be normal tha, second be normal tha, inko to kuch hai nahi. So they thought, so I'm talking about, so sometimes you're just surprised. And obviously these kind of things stay in your head forever.
Dr. Akash Keshri, our obesity expert, has a question.
Thank you so much, sir, for an enlightening presentation. I think vertigo is something that we find difficult to treat in clinical practice. Easy to diagnose, but turns out to be a little challenging. And one of the questions that I had was that one of the questions which I had was in terms of benign positional vertigo, how do you see the role of vestibular exercises? You had mentioned an app which is present in the role of the treatment of the same, and what frequency do you recommend at a practical level that the patients sort of implement? Daily, every other day? How can they, in a practical way, make sure that they are doing the exercises in a way that they will have an effective treatment of their benign positional vertigo?
So the treatment of these paroxysmal vertigos is the repositioning maneuvers, and sometimes you have to repeat these repositioning maneuvers because they may not always be successful. So you may have to do 2 or 3 depending on how good you are. So a person who's very good at it will manage to do it the first time. Somebody who doesn't do it a lot may take 2 or 3 attempts to do correct repositioning. But after you're done with that, my impression has always been that all these patients will be helped by the Brand-Daroff maneuver or even these. So it probably helps more with people who have these not specific causes also. So you're just allowing for vestibular rehabilitation and vestibular complex. So this app is, each of these videos would take less than 1 minute to do. Even if you do all 11 of them. I suggest that they do it every day, at least 2 sets of each. So it takes about 20 minutes. Some of them are standing and some of them are sitting. So some people are very old, they can't do the standing exercises. So half of them are standing. So if you just do the ones that you do sitting, you take maybe about 7-8 minutes for one set, another 7-8 minutes for another set. 20 minutes daily is what I recommend. And I tell them to continue this indefinitely. I tell them it's like going for a walk. If you want to keep your health, and if you've been suffering, just think that you need to continue this for a long time.
Thank you, Dr. Reddy. I think we had a wonderful session on vertigo. It's my privilege to ask Dr. Puja to give us a carry-home message for all our physician friends about vertigo, the red flags, and when should we refer the case to you. Ma'am, it's here.
Hello. So I think red flags.
Yeah, you're audible.
So the red flags, I think we have been very clear about the clinical symptoms, neurological signs, comorbid conditions, and a lot of headache associated with the vertigo symptom, acute onset. All those things favor the central cause over the peripheral cause. Second thing is, we do not have to hesitate in doing the MRI, even if there is slightest of the suspicion. Do not hesitate in doing the MRI, because missing a stroke will be more dangerous than just making a clinical judgment. Third thing I would like to highlight that I think cervical spondylosis and orthostatic hypertension are 2 things which have been commonly caused and known to cause, or maybe diagnosed commonly by general physicians as a cause of vertigo. And I am glad that in today's discussion there was no word about these.
I would have asked that question, but I left it to you to mention.
Yeah, so they are no longer considered to be cause of vertigo anymore. And we now very clearly know that only with very, very severe cases of cervical spondylosis who have like completely degenerated intervertebral disc and spine which carry the position sense. If they are damaged, then only we find the cause of vertigo. The label is that because of the cervicogenic vertigo. Otherwise, there is no role of, like, because we know that cervical X-ray will show some, in a vertigo case, cervical X-ray will show some changes of cervical spondylosis, but that is a reactionary impression because patient doesn't want to move his neck anymore because of the vestibular movement simultaneous. So because of the restriction of the movement and maybe the use of cervical collar, we still see in today's era also that people are using cervical collar also. So we try to discourage it as much as possible, that is one important thing. And another thing is, I want to highlight here and that the over-the-counter use of Vertin has made it, like thanks to the marketing team of Vertin, that even if you don't prescribe it, patient will take himself or herself on that company. Then it becomes very difficult to do the disc sulfide test at that time. It comes to be pseudo-negative. Then again, the clinical history plays an important role in that. That you have to restart from the beginning. Sometimes we say that stop Vertin for a day or two, and then you come to us and you do the disc sulfide at that time. When you are very, very sure that it is just a positional attack.
Thank you, Dr. Puja. Thank you, Dr. Reddy, sir. Thank you, Dr. Bhaskar Shukla. I would request all three of you to be please present here. Lalit, can you come here? Dr. Manavdeep Singh, Dr. Rajiv Ahuja, can you please come here? Group photograph, Dr. Naveen. Dr. Manoj Bidha, Dr. Sukhpreet. Dr. Renu, your student is here. Dr. Manoj Bidha, I think you can come here. You can come here. Dr. Manoj Bidha. She joined us. Yeah, she joined us faculty in 2002.
एक बार क्योंकि आप भी आ जाओ तो खींचेगा यार
रेड्डी के साथ
इसको दे
एक फ्री कंसल्टेशन मिल जाएगी हाँ अगली बार क्या चल रहा है
ले ले यार क्या कर रहा है
ले ले यार एक अच्छी फोटो ले
क्या कर रहे हैं
हमें I want to be in the same frame as Dr. Rajashekhar Reddi, Dr. Bhaskar Shukla and Dr. Puja.
हम भी आने चाहिए बाकी
हम लोग incidental हैं I would request Dr. Rajashekhar Reddi to please have his dinner. He is in no mood. He is about to disappear. And I would request Dr. Puja and Dr. Bhaskar to please have something from the spread. कुछ ऐसे नहीं ऐसे जाने नहीं देंगे सर हम आपको जाने नहीं देंगे
क्रिटिकल केयर में आके इसमें क्या करके और यूँ ही ब्रांच एग्जीक्यूटिव में होगी हम लोग ये में एग्जीक्यूटिव मेरा तो 2 साल वोटिंग राइट है इसमें और